let's get on to the next session. The next session is to be chaired by Professor Manikandan sir and Dr. Ashok Venkatraman from UK. Professor Manikandan sir is the senior consultant physician now practicing at Chengalpet, retired from government service in 2007. He worked as faculty in the Department of Internal Medicine in various medical colleges in and around Kanchipuram and retired as professor and head of Department General Medicine in KIMS. Professor Manikandan has kindly consented to chair this session. The other chair, Dr. Ashok Venkatraman, MD, FRCP, is a consultant cardiologist at George Eliot Hospital NHS Trust, Nuneaton, and is the associate clinical professor at Warwick Medical School, Warwick University, UK. He was the winner of the Hassan Pouthous Marie Care Memorial Endowment Prize in Cardiology in JIPMER. His special interests include heart failure therapies, including insertion of complex cardiac devices, an interventional cardiologist, a clinician par excellence, and a well-informed academician. We are thankful to Ashok for sparing his time to be with us despite a hectic schedule. Thank you. Dr. Professor Manikandan sir and Dr. Ashok Venkatraman, the stage is yours.
Good afternoon. It is a great pleasure to be with KIMS Medicon 2020, and I thank the organizing committee and the Covidology Institute of Medical Sciences for giving me this opportunity to be here on this session, and I am sharing the session 2. As you all know, this SARS-CoV-2 infection 19 is a pandemic not only in India and also globally, though it is somewhat controlled in India, especially in Tamil Nadu, and it is still a surge in everywhere all over the country, and including in India also, Delhi, Maharashtra and other states. COVID-19 is an RNA virus, a single-stranded RNA virus involving most of the vital organs in our body, like lung, heart, liver, kidney, intestinal tissue, and also hemopoietic, neurological, and immune system. Today we are here with us the eminent speaker, Dr. Muhajir Mohammed. He is a well-known hematologist and Director of Hematology, Launceston General Hospital, Australia. He is also a clinical associate professor in the University of Tasmania, and also as acting as a chief bone marrow transplantation committee, Northern and Northeastern Tasmania, Australia. I wholeheartedly welcome you, sir, on behalf of the Department of Internal Medicine and the Covidology Institute of Medical Institute and Research Center. Over to Dr. Muhajir Mohammed, who is here to enlighten us on the hematological aspects of COVID-19. Over to Dr. Muhajir Mohammed.
Vanakkam and good morning to all the virtual audience in India and elsewhere. Firstly, I thank the organizers for organizing this symposium on COVID-19, and my special thanks to Dr. Ramachandran for his invitation to contribute to this meeting. This is a COVID world map in end of January this year, and as you can see, apart from Wuhan province in mainland China and a few Southeast Asian countries. There were no other countries in the world which were involved, and the cases were less than 8,000 at that time. In contrast, if you can see the current global data, it shows 56 million cases and deaths of more than 1 million. This says the sad story of the devastating effects of COVID-19 on the humanity. If you have watched the movie Castaway and imagine this caricature is Tom Hanks waiting for a rescue ship for more than 10 years, this cartoon is not an exaggeration at all in the present scenario of what is happening all over the world. The topic for my presentation is hematological aspects of COVID-19, and this is the outline of my presentation. I'll start with blood abnormalities in COVID-19 and then go through thromboembolism, which is a major cause of morbidity and mortality, and management of thrombosis. I'll also touch base on convalescent plasma and its advantages in COVID-19. COVID-19 is a systemic infection with significant impact on hematopoietic system and hemostasis. The blood changes in COVID-19 include low lymphocyte count, low platelet counts, and white cell counts, among which lymphocytopenia is the most common of more than 80% in many of the studies, followed by thrombocytopenia and leukopenia. All these changes are found to be more prominent among the severe cases than non-severe cases, as you can see, 96 versus 80% for lymphocytopenia, 57 versus 31% for thrombocytopenia, and 61 versus 28% for leukopenia. And lymphocytopenia is one of the laboratory findings found to have a very poor prognosis if it is very low in COVID-19 patients. Coming to coagulation abnormalities, elevated D-dimer levels are reported consistently in many studies, and gradual increase of D-dimer during the course of disease is also associated with worsening of disease and poor prognosis. Elevated D-dimers of more than 0.5 milligrams per liter was found around 46% with confirmed COVID-19 patients, and like the other markers, these are more pronounced among severe cases than non-severe cases. Other coagulation abnormalities such as prothrombin time, activated partial thromboplastin time prolongation, fibrin degradation products increase, and severe thrombocytopenia consistent with the picture of DIC can be a marker for severe infection and also can lead to life-threatening DIC and death. There is an emerging role for biomarkers in monitoring COVID activity and the trend of COVID-19 patients who are sick. Procalcitonin, ferritin, and C-reactive protein are studied for COVID activity and monitoring the trend. Higher CRP levels has been linked to unfavorable aspects of COVID-19, such as adult respiratory distress syndrome development, higher troponin T levels, myocardial injury, and death. Higher serum ferritin was associated with ARDS development as well. And Increased IL-6 levels are also associated with increased risk of mortality in many of the studies. Now moving on to clotting and bleeding complications in COVID-19 patients. This is a graph which shows the thrombotic and bleeding risks in critically ill COVID-19 patients in a French study. Thrombotic events were above 40%, and majority of them were pulmonary embolism, DVT or deep vein thrombosis, and combination of DVT and PE, which will be about 80%. And the arterial thrombosis such as ischemic stroke, acute coronary syndrome, acute limb ischemia, or acute mesenteric ischemia were only around 20% among all the thrombotic events in critically ill patients. Bleeding risk is much lesser, about 20% in critically ill patients, and these are distributed in various organs, with deep muscular bleed being the commoner bleeding site. This picture shows the pathophysiology of thrombosis in simple terms. The left side is the normal lung and alveoli and the capillaries, and the right side is the COVID-19 infected alveoli, which shows severe inflammatory reaction due to SARS-CoV-2, leading to cytokine storm, microvascular thrombosis in the lungs, endothelial cell activation and damage due to virus binding to ACE2 receptor increase the risk of thrombosis. COVID-19 patients, whether hospitalized or ambulatory, are at a very high risk of thromboembolism. Venous thrombosis is much higher than arterial thrombosis, as I already alluded to. Prolonged immobilization during illness, dehydration, acute inflammatory state are all risk factors for thrombosis. The other trigger factors include cardiovascular risk factors such as hypertension, diabetes, obesity, or presence of underlying cardiovascular disease, presence of underlying cancers, or previous history of venous thromboembolism also adds to the risk. In patients who are critically ill, mechanical ventilation, central venous catheterization, and surgery induce vascular damage and increases the risk of thrombosis by a higher level. The combination of DVT and fatal PE can lead to morbidity and mortality in COVID-19 infected patients. Now talking about management of VTE, both prophylaxis and treatment. All hospitalized adult patients with COVID-19 should receive pharmacological thromboprophylaxis with low molecular weight heparin, which is preferred over unfractionated heparin. This should be done universally except in patients who are at high risk of bleeding, which outweighs the risk of thrombosis. However, in the setting of heparin-induced thrombocytopenia, drugs like fondaparinux is recommended.